First, I'd like to thank the organizers for giving me the opportunity to present on malaria. It feels like it's pretty rusty, like I have not seen any malaria cases since COVID started. But nevertheless, it's still, I think it's a pretty big burden in the region. So I'll start off. Plasmodium Vivax, it's been historically termed the benign malaria as compared to its cousin Plasmodium falciparum. And I'll start off by talking on the epidemiology in the region and in globally. So it's still a actual global pathogen. It's a parasite, causes about 7.5 to 14.3 million cases per year. This is record data from the Malaria Atlas project published in the Lancet in 2019. So you can see from the ring, 48% of the burden is in India, and Pakistan, then followed by Ethiopia, Afghanistan, Indonesia, and others, with Brazil, PNG, Sudan, and Venezuela making up the bulk of the cases in the countries in the gray zone. In the region, in the Asia Pacific side, that there are 22 malaria endemic countries. So 3.9 billion of the population in the Asia Pacific region are at risk. 1.9 billion at a risk of malaria out of a 3.9 billion total population. Reported in 2019, 9.6 million cases per annum of falciparum, and then there's 12.2 million cases per annum of P. Vivax. So Vivax has actually overtaken falciparum in the region, actually. And the global cost of P. Vivax is about US dollars 343 million per year estimated. You can see. Now the national incidence of P. Vivax malaria is in 49 countries. You can see the incidence varies, but it does highlight that even countries that we normally don't think of as having malaria, such as South Korea and North Korea, actually do have Vivax malaria, and at a pretty high incidence as well. For Vivax mortality, this is data from 2018 in the WHO Sierra region, about 1,800 deaths per year, constituting 7% of all malaria deaths. In the Wipro region, about 700 deaths per year, accounting for 17% of all malaria deaths. Most deaths, when documented, are from ARDS, or acute respiratory distress syndrome, anemia, shock. Cerebral malaria is a bit less common. Vivax actually again affects countries and populations within those countries that are most vulnerable and most socially disadvantaged. So on the figures, you can see the greatest burden of P. Vivax is in children and in rural areas. So you can see Afro, Ambro, Paho, Sierra, and Weka Wipro. Infants and children actually bear the biggest burden. And again, if you look at the proportion of P. Vivax cases in rural areas, in certain regions, it's almost 80, all are more than 50%, and up to 80% actually affect rural populations. With a lot of money being spent, both privately and by governments, to actually eliminate malaria, the effect has actually been good. So there was a downtrend from the early 2000s in the Plasmodium falciparum. However, the interesting observation is that this has then led to a so-called rising proportion of the malaria now is due to P. Vivax. So you look at countries in Thailand and Indonesia, you can see Vivax on the red line going up as falciparum is coming down, and Indonesia is the same, and then Brazil and Colombia as well. And if you look at, again, all the WHO regions, you can see that the Vivax is now the dominant species of malaria in most co-endemic countries. Some of the key biological features of P. Vivax that drive this, this characteristic of being difficult to actually eliminate is one, they have a dormant hypnozoite, which is the liver stage, and then that's requires actually special therapy, and this actually enhances transmission and geographical spread. Actually, the second feature it has is probably the early formation of actually gametocytes. So in Vivax, the gametocytes form even before the patient gets sick, and so they're able to transmit the gametocytes to the vector, and then it's harder to actually eliminate in that sense compared to Plasmodium falciparum. I'll talk a bit more about the clinical features here. Now, no, it's actually the clinical features in general are pretty straightforward. It's fever, with and without actually severe symptoms, but they tend to vary. If you look at this picture in areas that have high transmission and low transmission. So in areas that have high transmission, it affects children, and they end up, most of the time they present with fever or actually anemia, or sometimes respiratory distress. And they have a higher kind of parasite population density and diversity and structure. As you go down to countries that have either eliminated or have very low transmission levels on this side, you can see that it's mainly imported cases, and it presents in what I call specific high-risk groups that either have traveled abroad for business or have occupations that expose them to the vector. I'll talk a bit about severe Vivax malaria and is it under-recognized? So traditionally, for a long time, until the early 2000s, Vivax was thought not to be associated with any mortality or any morbidity. It was just like a benign parasitic infections. Some studies have shown then since that this is not true in a general sense. The meta-analysis of clinical studies since 1900s, this was published in 2014, had 77 studies. Again, most of the studies from India, some from America, Indonesia. Now, interestingly was that because the criteria at that time was not fixed, actually most of the studies had no reported severe Vivax. But in this meta-analysis, the case fatality was about 0.3%. Now, again, you can look at the some of the various complications in severe Vivax that have been reported in the literature. And again, there's death, cerebral malaria, multiple convulsions, renal dysfunction. So it can look, for all intents and purposes, to look like falciparum malaria, but just at a lower, what they call a lower risk than that. So, okay, now one of the main differences between Vivax and malaria is the capacity for Vivax to relapse, which means that if you treat a patient just with a blood stage anti-parasite therapy without treating the liver stage, Vivax tends to come back. And it can come back if a different time, kind of time patterns. So if you look at the short latency, the so-called Chesson strains, which are found actually in the Asia Pacific near the equator, first described actually in Papua New Guinea and Indonesia. The relapse comes back very fast. So it can relapse as early as 3 to 4 weeks after your initial infection, and it tends to kind of recur unless you what I call treat it with unless you treat the what I call hypnozoite stage. And then there's intermediate, and there's long latency, such as the Madagascar, St. Elizabeth, McCoy strain, and there's long latency. This is found in mostly temperate countries like South Korea. And so someone can go to South Korea, and if he visits some of the high-risk areas like the demilitarized zone near the North and South Korea border and comes and has Vivax malaria, they can actually present only about 6 to 9 months later. Right? So it's quite it depends where you get your primary infection. The latency periods can really vary quite a bit. Talk a bit about diagnostics and what's new in the last 10 years. There has been quite a bit of change. Conventional Vivax Diagnostics, again, this is almost more than a century old technology. We, thick and thin blood smears, the sensitivity is about 50 to 100 parasites per microliter, which is roughly the pyrogenic threshold for Vivax. However, it does require laboratory resources and trained staff. And one of the challenges we have found, like when I was working in Malaysia and parts of Indonesia, was that with the decrease in the incidence of malaria, the lab staff do become less and less skilled in actually recognizing malaria, and especially the younger ones that come up to take up actually new jobs. So and that requires constant training and kind of constant quality control, which can be difficult. Okay, and then for there's first generation LDTs, and then this is Plasmodium Vivax lactase dehydrogenase, PV aldolase. So the first generation, unfortunately, the sensitivity was much lower versus microscopy. Since then, with a lot of funding from government and private agencies like the Gates Foundation, a lot of new diagnostics that have come out, that ultra-sensitive LDTs, HEMEX, Vivax, rapid serology, autoscope. So all this now, the ultra-sensitive LDTs are probably as good as microscopy now. They can go down to about 50 microliters to about 100 microliters. And so LDTs for Vivax now are pretty reliable. And you can go onto this Vivax Malaria site to actually look at the performance indices for all the new diagnostics that have been released and are in the market now. Okay, and I'll talk about case management. Again, Vivax has unique features that different from Plasmodium falciparum. So on the red side, you see you have to treat, there's a what I call schizontoscidal treatment, which means you treat the blood stage of the parasite, and that's chloroquine, DHP, and artemether lumefantrine. You can see the mosquito biting, and then there's a blood stage, and there's a stage that goes into the liver cells. But for Vivax, you also need to treat the hypnozoids, and that's, you have the only two drugs available, that's primaquine and tafenoquine. And again, for falciparum, you don't have to treat that. So this is one of the reasons why it's harder to actually eliminate, because you need to treat the liver stage as well. You can see that's the blood stage, and that's the liver stage where you have to treat. Yeah. One of the main concerns has been in treatment of Vivax malaria has been chloroquine resistance. So again, there are areas that have high levels of chloroquine resistance, and this is a map from showing levels of chloroquine resistance against Vivax from 1985 to 2019. And look at the category 1, blue, it's mainly in the Southeast Asian region. There was a paper done by one of my colleagues in Australia, Rick Price, looking at chloroquine-resistant P. Vivax. This was a systematic review, 57 chloroquine-resistant sites defined at day 28. What they found was that actually the methodology for a lot of the reports was not well reported. So in terms of, they did not measure the chloroquine levels in the blood, they did not account for poor absorption, they did not look whether it was relapse versus recrudescence. So currently, the best data and evidence only shows high-level chloroquine resistance in Indonesia and Papua New Guinea. We documented high-level resistance in Sabah in 2014, but they have done a good job and have actually eliminated the human forms of malaria, with the last case reported in 2020. Now they have other issues with nosai malaria, which my collaborator Tim William will talk in the next talk here. And again, what happens when you have chloroquine resistance? And this is a slide, sorry, it's a bit small. And you can see in scenarios of low, intermediate, and high levels of resistance, this is the parasites, amount of parasites. Green line is the sensitive parasites, and this red lines are resistant parasites. So basically what it means is that if you have low level resistance, you can relapse at a later time. If you have high level resistance, and what intermediate and high level, the relapse happens a lot faster because of once they pass the MIC, it just tends to grow again. Now, what happens if you have chloroquine resistance? So data again shows that it's artemisinin combination therapy for P. Vivax. So this was reviewed in a systematic review in 2019. Again, most of the data is for DHP or dihydroartemisinin piperacin and artemether lumefantrine. And if you look at it, basically what it says is that they both work well in the acute stage, but because of the short half-life of artemether lumefantrine, the lumefantrine component, there's if you don't treat them with primaquine, there's the relapse is higher and faster in the group that gets artemether lumefantrine compared to DHP, and this has been shown in multiple studies. So ACT for Vivax has currently been recommended Indonesia, Vanuatu, Solomon Islands, Malaysia, and Cambodia. And delaying relapse actually does have a strong clinical outcome. It improves actually the hematological recovery, which is actually very important for children who then have impaired growth, and malnutrition if they have become chronically anemic. So the choice of the ACT you use actually does make a lot of difference. One of the interesting observations was that with the use of ACTs for Plasmodium falciparum, there seems to be an increased risk for that almost triggers a Plasmodium Vivax to come up after the falciparum has been successfully treated. The biology and the reasons behind it is not quite clear. It's thought to be short relapse periodicity, short half-life, or been triggered by Plasmodium falciparum fever. But basically, it's not been well. Still, the reasons are still not clear. So after ACT, the greatest risk of recurrent parasitemia and transmission is from P. vivax. It's not from P. falciparum. So this is one of the strange kind of observations they found in clinical studies. Now, some people have argued whether there should be a universal treatment of uncomplicated malaria, so you don't have to consider whether the parasite Vivax is chloroquine resistant or not, and it helps to make the treatment protocols much simpler in endemic countries. So current recommendations is P. falciparum, it's ACT, P. vivax is chloroquine, or ACT plus primaquine, mixed species ACT. So some of the some experts have kind of proposed a universal radical cure where you just use ACT plus primaquine or tafenoquine for all species, whether it's falciparum, vivax, or mixed species. Again, the potential benefits as mentioned, there's reduced Vivax infections, decreased associated morbidity, reduced Vivax transmission, and some pragmatic or practical advantages. But again, the risk of PV varies, so it may not be applicable to all locations. Now, radical cure, this is again unique to Vivax malaria, and this refers to getting rid of the liver stage. Now, there are only 2 drugs, and again, the primaquine efficacy is related to total dose administered. And again, it's ranges from tafenoquine in a single dose to what they call short course primaquine to long course primaquine, okay? But the issue is that you need G6PD testing. So one of the main complications of tafenoquine and primaquine, the both drugs are 8 aminoquinolines. They induce hemolysis in G6PD deficient individuals. You see tafenoquine, primaquine, and then now patients don't complete a 14-day regimen for an acute febrile illness. So primaquine efficacy is related to total milligrams per kilogram of dose ingested. Clinical trial done in Ethiopia, and you look at if you complete your clinical course, you have only 8% relapse. If you don't complete, incomplete, or unsupervised course, it goes down to 73% and 63%. Okay, in clinical practice, this is under a clinical trial scenario. Clinical practice in Papua, Indonesia, unsupervised, the effectiveness is only 10%. Okay, so people don't take their 14 days of primaquine. G6PD, again, if you look at if you're at 30%, your risk for hemolysis is low. If you're at 70%, it's very low. And it needs to be quantitative. I mean, it needs to have a test before you actually, in developed countries, you undergo G6PD testing before you are given actually primaquine. And you can see that for field kind of research, there is a new, I mean, for field use currently, there's CareStart, there's a screenings kit, and then there's also a new one by SD Biosensor, which works quite well, but however, they are expensive to be deployed. The LDT can be, but I think there's more data that needs for the G6PD LDT. No. Now, short course radical cure. Tafenoquine is a 1 dose, 300 milligrams. So this was done in the detective study, Brazil, Peru, Ethiopia, Cambodia, and Thailand. It used only chloroquine as the blood stage agent. Patients had to have a G6PD level above 70% and age above 16 years old. And basically what it found was that it was comparable to chloroquine. Short dose primaquine, 7 days versus 14 days. This was improv study done in Indonesia, Vietnam, Afghanistan, and Ethiopia. Both short course and long course were actually about the same. So there was no decrease in efficacy with the short course. However, there was, and there's also not much risk of severe hemolysis. Again, and you can see here some of the data you saw about PV-induced severe hemolysis from primaquine is actually quite low. One in 600,000, and one in 48,000, and one in 10,000 in various studies. There is a potential benefits of radical cure in that your hemoglobin recovery is much, much better if you receive a radical cure. As you can see here from various studies. So almost ending. Just a few take-home points for tafenoquine. It has a very long half-life versus primaquine. 14 to 28 days versus 4 to 6 hours. So if a patient has some form of G6PD deficiency, there's a risk of severe hemolysis. You cannot stop the medicine. It will keep on hemolyzing until the red cells are all gone and has to be replenished. Again, the clinical studies only enroll patients with greater than 70% G6PD deficiency. There's no synergistic effect with ACTs compared to chloroquine. And currently it's only licensed in 5 countries, as far as I know, USA, Australia, Brazil, Thailand, and Peru. A bit on radical cure in G6PD deficient individuals and pregnant women. So weekly primaquine for 8 weeks. This is for G6PD deficient individuals, very little safety data. Should have access to medical care and transfusion services. One study from Cambodia showed significant but very transient drops in hemoglobin following weekly primaquine. For pregnancy, primaquine and tafenoquine are contraindicated, so weekly chloroquine for prophylaxis is recommended. If it's in a chloroquine-resistant area, there's very little data, but most of us would use ACTs. So Vivax elimination, yes, early diagnosis and treatment key to Plasmodium falciparum elimination. It's less effective for Plasmodium Vivax. The hypnozoite stage and the need for radical therapy make it more difficult. Theoretically, all the tools needed for elimination are actually already available, but on the ground implementation in resource-poor countries is still very, very challenging. And having been on the ground myself, I can see the difficulties with that. So with that, I'd just like to acknowledge all the collaborators and colleagues, both past and present, that have worked with me on my various malaria projects. So this includes a whole group in the Menzies School of Health Research where I used to work, as well as Bruce Russell and Noi in University of Otago, and Dr. Timothy William and Dr. Giri in Sabah, who have contributed a lot to malaria research in the region. And I'm happy to take any questions.
Thanks, Ingwen. While we're waiting for questions to come in, that was very, very informative. In fact, I think I learned a lot more and you answered a lot of the questions that I have, even like, things, what do you do when people are completely deficient in G6PD? I think you mentioned that it's a weekly dose of Primaquine, and I think that's what we try to go by as well. The other thing I'm curious about, and that's because of my background in Indonesia, we realized that the capability to look at the microscope for the malaria parasite is dwindling as we don't see a lot of it. In all these developing countries, what is the tool that you use to help them diagnose? Is it all by RDT?
Yeah, so I think now Indonesia-wise has gone on to RDT. So last time I was in Papua, 2018, 2019, they still had microscopy, but in the clinics. So they had the microscopy in the outpatient clinics in the hospital and with a lab attached. But when you go out to the so-called the rural clinics, it was all RDTs.
Okay.
And I think now, again, because of the new generation ones, I think even for Vivax, they work quite well. And I think they work well enough for deployment. Now, the good thing about Vivax is that it normally there's no fast fatal outcome like falciparum. It's just that the patient, the child, whoever gets chronically sick. And so, but yeah, the new generation RDTs work very well.
Okay, so in places like Singapore, we actually have not moved to RDT. We actually use a lot of microscope where possible, and of course PCR.
Yeah. I think here, I mean, to be honest, last year I'm not sure how many cases of Vivax we had. I think 2019 I saw we had like 200.
Much less now.
Yeah, much less now. I think once travel has been banned, I think our QC here and all that, I think I would say probably microscopy would still be the option here with our numbers and our lab resources.
Can I extend on Limin's question? So let's say in Indonesia, where now RDTs are the mainstay, but normally the SOP is if RDT is positive, we'll still back up with microscopy.
Yeah, if it's available. Yeah. Now the issue with RDT is that you don't know whether it's previous or current infection.
Absolutely.
And that is one of the problems. So I would say in Indonesia, not so much of an issue. It's more of an issue in Africa, where there's a lot of transient, there's a lot of asymptomatic Plasmodium falciparum. So if the patient may come in with a fever, is RDT positive, you assume that it's due to the malaria, but actually they got something else, maybe typhoid or something else. Yeah.
Okay, I've got a question here from my anonymous asking, can you comment on the impact of zoonotic P. cynomolgi on the epidemiology of Plasmodium Vivax?
Yeah, so I haven't followed this up for a while, but currently I think I'm not sure there's only been 1 or 2 cases of cynomolgi been reported as a human zoonosis. I haven't followed up. Now, it was actually the first simian malaria found to be crossover that was in the lab actually. So there is potential. Why it hasn't crossed over as much as nosai is a question that I think a lot of people are trying to answer. I think Laurent, maybe I don't know, maybe they want to comment later, but yeah, so it's one of those mysteries. So we have looked for it, and we did do when I worked in Sabah on one of our projects, we did PCR almost all our malaria to look for, I think, Inui and cynomolgi, just in case there was co-infections with nosai and stuff. But for some reason, we did not find it. Yeah.
Okay, because that will explain the subsequent question is whether it leads to misdiagnosis, but we did actually double check with the PCR.
Yeah, but I think some other, it has been reported, so and it has been shown to already cross over in certain circumstances.
Okay, that leaves us to have a look at what will happen at that arm. Thank you very much. Then we'll move on to the next speaker.
Yeah, thank you.
Thanks, Simon.